Now, in the fourth section of our lecture, we will talk about chronic hypertension. And when we will talk about chronic hypertension, we will discuss what are the causes of chronic hypertension, what chronic hypertension leads to the complications, especially maternal risk factors, and then we will talk about the management of chronic hypertension. So first, chronic hypertension, as we mentioned in the previous slide, we discussed about this, that in the pregnancy, usually we have gestational hypertension and then pre-eclampsia. Chronic hypertension will be the women who become pregnant and they already have high blood pressures and they are on the treatment for high blood pressures. So chronic hypertension is high blood pressure that was present before you became pregnant, or that occur in the first half of your pregnancy also. The other difference, we said that pre-eclampsia usually occurs after 20th week of pregnancy, but chronic hypertension is present before the women become pregnant, or it occurs in the first half of the pregnancy. Chronic hypertension has effect on different parts of the body or different structures or organs of the body. In the brain, it causes cerebrovascular accidents can occur with high blood pressure, strokes, or there may be hypertensive encephalopathy, confusion, headache, and convulsions. All these can occur with high blood pressure. Eyes can also be affected, known as hypertensive retinopathy. In the blood, there are elevated sugar levels. Then in the heart, there might be heart attack or heart failure. Kidneys, there is chronic renal failure and hypertensive nephropathy. So all these are the complications of chronic hypertension if patient has high blood pressure that is over the longer duration for long period of time. Causes of chronic hypertension, different causes, idiopathic, in which no cause is known, and there are cases of high blood pressure in which there is no known cause of high blood pressure. Essential hypertension, vascular disorders, any disorders of the blood vessels can cause high blood pressure. Renal artery stenosis, coarctation of aorta, renal disease, polycystic disease, diabetic nephropathy, chronic glomerulonephritis, nephrotic and nephritic syndrome, collagen vascular disease, systemic sclerosis, SLE, rheumatoid disease, endocrine disease, pheochromocytoma, Cohen's syndrome, Cushing syndrome, and diabetes mellitus. So lot of causes that can lead to high blood pressure, mainly due to their effects on the blood vessels and the effects of the different hormones, different enzymes that can affect the blood vessels, ultimately leading to vasoconstriction, increased resistance to blood flow, and increased blood pressure. So different causes can lead to high blood pressure. The risk factors that can occur as a result of chronic hypertension: pre-eclampsia, abruptio placenta, heart failure, and intracerebral hemorrhage, which are the strokes. So it can cause pre-eclampsia in pregnancy. It can cause abruptio placenta, in which the placenta separates from the wall of the uterus, leads to hemorrhage. It can cause heart failure and stroke. The management of patients with chronic hypertension, consultation is important. Schedule additional appointments based on individual needs. Additional appointments are important to find out the status of the patient regarding high blood pressures, because it can cause complications and even increase fetal and maternal mortality rate. Timing of birth is important. If blood pressure is less than 160/110, with or without antihypertensive treatment, do not offer birth before 37 weeks. After 37 weeks, timing and maternal and fetal indications for both should be agreed between women and obstetrician. So if blood pressure is not very high, less than 160/110 without treatment, usually it's better to wait until the baby or fetus reach the viability stage, and should not be should not be performed before 37 weeks of pregnancy. If patient is on antihypertensive treatment, stop ACE inhibitor and angiotensin. And so any angiotensin converting enzyme inhibitors. So if patient is on ACE inhibitors, stop the medicine within 2 days of notification of pregnancy, because if patient becomes pregnant and it's chronic hypertension, so most likely the patient or the pregnant women is already on antihypertensive drugs, so they should be stopped. Offer antihypertensive treatment depending on pre-existing treatment, side effects, and teratogenicity. So drugs that are safe during pregnancy, they should be used. Aim for blood pressure that should be less than 150/100, and usually if the secondary chronic hypertension, offer referral to specialists in hypertensive disorder. Fetal monitoring is important with the chronic hypertension. At 28 to 30 weeks and 32 to 34 weeks, carry out ultrasound, fetal growth, and fetal amniotic volume. And then if fetal activity is abnormal, carry out cardiotocography. So overall, the aim of the management is the fetal assessment and assessment of fetal well-being and maternal well-being. If fetus is well-being is normal, a biophysical profile testing, if non-stress testing, and if cardiotocography is normal, usually it's preferred to wait until the fetus reaches the stage of viability, then delivery should be performed, and usually it's elective C-section is performed if there is low level of amniotic fluid or if the patient is hypertensive. Risk factors for developing superimposed pre-eclampsia on chronic hypertension. We have renal disease, maternal age more than 40 years, pre-existing diabetes, multiple pregnancy, connective tissue disease, coarctation of aorta, blood pressure more than 160/100 in early pregnancy, pre-pregnancy body mass index more than 35, previous pre-eclampsia, and antiphospholipid syndrome. So all these are the risk factors. If present, there are chances that women with chronic hypertension will lead to pre-eclampsia with proteinuria and high blood pressure, and further complications of pre-eclampsia, which we already talked and discussed about. So that was all about chronic hypertension. Thank you for watching sqadia.com.